I am a cognitive and movement disorders neurologist at the University of Colorado, meaning I specialize in both thinking and memory, as well as movement disorders. I practice primarily in our memory disorders clinic, though, because I usually don't see people with Parkinson's if they don't have thinking and memory or behavioral changes. But I am also in the movement disorders section and work very closely and act as a bridge between the two, because Parkinson's disease and related conditions really does bridge thinking and memory and movement of our bodies. So when I was going through my training and I realized as a movement specialist that I wasn't able to take as good care of my patients as I wanted to without the extra training and knowledge of thinking and memory, I did more training. So I did 3 more years afterwards. I have a lot of degrees on my wall, but it lets me take care of my patients as people, not just, I only do this part, you need another doctor to do that part, right? And I feel like healthcare on the whole in the United States has kind of moved too far to subspecialists, right? So I tried to do my own little part by doing a little extra training in the two, but I primarily work in our memory clinic, and I'm the director of our Lewy Body Dementia Center of Excellence there, and we're going to talk about Lewy Body Dementia and how that intersects with Parkinson's and what we're going to talk about today. As Jody alluded to, this can be a very sensitive and stigmatizing topic, right? The reason why I titled this topic Hallucinations and Delusions and not psychosis. Psychosis is a word that's been very stigmatized and is used incorrectly. It's become pejorative, right? It's an insult to say somebody's psychotic. All psychosis means is an alteration in how a person is perceiving reality. What is reality? It's what we all collectively decide is real, right? But it's all made up by our brains. Everything's made up by our brains. But psychosis is typically manifested as hallucinations, seeing, hearing, feeling, tasting, smelling, things that are not really there, and delusions, which are false, fixed beliefs, even if there's evidence to the contrary. So we're going to go through what these things mean, what they can look like. Very frequently, people are experiencing some of these things and they don't even realize it's a hallucination or a delusion, or loved ones don't realize that it's a hallucination or a delusion. But the take-home message is that these things are common. You need to tell people about them because there's treatments. Number one, treatments that might be making it worse, including some of your Parkinson's medicines, and then treatments that can make it better. But if we're going to destigmatize these things, we need to talk about it. Right? Okay. So this is a piece of art from a Mexican artist. His name is Octavio Ocampo. And when you look first, that's nice little trees, kind of bucolic setting there. And then the longer you look, the weirder it gets, right? So if you see a woman looking back over her shoulder between those two trees, if you look up to the left over the woman's face, there's a man's face looking down over her. And if you look over her right side, there's an older man with a beard. And then you look down at that nice little picnic at the bottom there, and you go, ooh, does that look like a body down there? So the longer you look at this picture, more things come out. There's actually also even faces. And so the human brain is primed to do this. From a survival standpoint, our brain wants to make sense out of randomness. And all of us who are alive today had ancestors who were good at detecting sense out of randomness because they survived, right? They were able to run away from that saber-toothed tiger that was trying to eat them, and their body could procreate and eventually became to be. To be alive today, most of us, there are some that are playing, but most of us alive today are primed to, in any environment, seek out order in the randomness, primarily from a survival standpoint of, am I safe in here? Is anything trying to eat me? Right. So this is a visual illusion. And you'll sometimes hear about optical illusions, right? And there's things that you can buy, and there's kids' books that have your mind kind of play tricks on you, and you'll see it, you look at it a different way, and we'll see a few other examples. But I always start with this because it's happening to all of us. The only difference for people living with Parkinson's is that it happens to them more. This is a normal human phenomenon that is more common in people living with Parkinson's. Destigmatize. So, these are our learning points. Please feel free to interrupt me. I usually try to keep these very informal, ask me questions, we can go off on tangents, but the more interactive it is, usually the more you take away from it, so feel free to interrupt me and raise your hand. Sometimes we go on total tangents way off into left field, and that's fine too. Use me if I can help, if I can answer questions for you. But we're going to talk about what psychosis is and how common it is. We're going to talk about the full spectrum of psychosis symptoms, from things that could be very subtle and mild, like misinterpreting a picture, up to more florid, bothersome, dramatic, or dangerous hallucinations or delusions. And that it's really important to have a conversation to talk about these things. Number one, because we can help them. Number two, to keep people safe. And number three, to destigmatize it. So, definition of psychosis, the difference in how the brain is interpreting reality. Am I in the way? I'm standing in front of the slides, aren't I?
You're fine.
You sure? Let's see.
Don't worry about it.
Is that better? Okay. So reality is what we all as human beings collectively decide is what's actually happening. It might be a little bit different between each of us, but it all aligns overall. And if our brain is telling us information that's different from everybody else, it's technically psychosis. Okay. Now, is that a hand? Yeah.
Well, as you describe it, psychosis is something that is, let me see here, you're making, as I heard, making something of your environment that is perhaps more detailed than one would normally. Is it the opposite as well? That is, do you miss things in your environment? Is that also a psychosis?
That's a very, very interesting question. Did everybody hear them in terms of, is psychosis just extra stuff, positive phenomenon? Or is it also negative phenomenon, missing things? It can be either. But usually the missing things, you don't know it's not there. And it's also less disturbing to say, I see a person standing over there. Does anybody else see that person standing over there? Versus, ooh, I didn't see you standing there, right? I missed you. So sometimes those negative phenomenon are not as obvious or bothersome to people, right? You don't know what you don't know. But it is any alteration in the perception of reality. But the extra stuff, the additional positive, seeing things, feeling things, hearing things, or believing things. But that's a really interesting point. Any other questions about definitions? Okay. So usually we don't start using the term psychosis unless it's a recurrent thing, right? If it's something that's starting to affect somebody's daily life, their function, their safety. But any time the brain is playing tricks on us, it's technically psychosis, right? But there can be reasons for it. Medications are the most common cause. A delirium, and we'll talk about that at the end too in terms of safety when you're hospitalized or sick otherwise. A delirium is a sudden acute onset of confusion during which there's often hallucinations and delusions. The brain is separated from reality. And that can happen when we're hospitalized, when we're kept up all night with beeping machines and people trying to come take our blood pressure at 3 o'clock in the morning. Medications, and we'll go through those medications, but a lot of really common ones, including over-the-counter ones. Psychosis is almost always in the community associated with psychiatric diseases, right? Schizophrenia. So schizophrenia usually starts teenage, early 20s, and the core feature of schizophrenia is the presence of hallucinations and delusions. Usually they're auditory hallucinations, they hear voices, sometimes voices telling them to do things or hurt themselves or hurt other people. And that is another big part of why this is so stigmatized. I mean, mental health overall is still stigmatized, right? And why is mental health different from health, right? It's all your brain. Your mind is your brain is your mind. But it's another reason why people don't bring these things up, because they assume I'm losing my mind. I'm going crazy. They're going to put me in a padded cell. I'm not going to tell anybody I'm seeing that person over there. I'm just going to keep it to myself. Right? So bringing this out into the open, number one, but also the fact that psychiatry is just the neurology we haven't figured out yet. It's all neurology. It's your brain. Of course it's your brain. There's no difference between the brain and the mind. The mind is the brain is the mind. And the only difference between what I as a neurologist and my colleagues as psychiatrists do is how we're trained to take care of people. But in my clinic, I take care of depression and anxiety and psychosis and sleep problems. It's all neurology. Again, bringing that separation of the fields closer together, right? Treating people, not pieces of people. Right? But in terms of psychosis not being a disease itself, the most important point here is that if somebody starts hallucinating or having delusions after adolescence, in their 30s, 40s, 50s, 60s and up, it is a neurological disease until we prove it's not. Most primary psychiatric conditions like schizophrenia, like bipolar disorder, or even just delusional disorders or other forms of psychosis, some people with depression can have psychosis too. They almost always start in our teenage years, 20s, maybe into our 30s. But the most common consult that we get, well, that I get because this is what I do, new onset hallucinations or delusions in a 60, 70, 80, 90-year-old, that's not schizophrenia. That's actually a Lewy body until we prove it's not. But again, people don't talk about it. They assume it must be psychiatric, and they are adhering to this false distinction between what's the brain and what's the mind. It's all your brain. So, Parkinson's disease psychosis. The presence of hallucinations or delusions, or both, can happen in up to 60% of people living with Parkinson's. 60%. Sometimes it's very mild and subtle, some of those visual illusions that I'll show you some examples of. And sometimes it's very distressing and bothersome. The presence of hallucinations does not separate Parkinson's from Lewy body. I hear that all the time. So-and-so is hallucinating, so if the Parkinson's diagnosis must be wrong, it must be Lewy body. We're going to talk about what Lewy body actually is and how they're really overlapping and on more of a spectrum than separate. It is more likely to have hallucinations and delusions if you're living with Parkinson's if you also have some cognitive changes. About 15 to 30% of people at the time they're diagnosed with Parkinson's already have what's called mild cognitive impairment. There's some changes in their thinking and memory. We can see it on our testing. They're noticing, their loved ones are noticing, but they're still independent. Now it gets a little dicey trying to judge independence for somebody living with Parkinson's, right? How we ask is, are you managing your own medicines? Are you paying your bills? Are you shopping? Are you driving? Are you cooking? That's how we measure daily independence. But for people living with Parkinson's, they can have trouble with those daily tasks because of their motor symptoms, because of their shakiness, their stiffness, their slowness. That doesn't mean they have cognitive impairment. So when we're assessing somebody with Parkinson's to see if there is also Parkinson's-related cognitive impairment, we have to be really specific. Why are you having trouble with these things? Up to 80% of people living with Parkinson's will eventually get dementia. That's about 5 times higher than people the same age without Parkinson's. Parkinson's dementia is very different from Alzheimer's dementia. And a lot of people use dementia and Alzheimer's interchangeably, right? It's the most common question I get in the memory clinic. Well, what's the difference between dementia and Alzheimer's? What do you mean it's not Alzheimer's? So dementia just means a decline in thinking and memory abilities to the point that the person is no longer fully independent. Starting with complicated things like paying bills or managing medicines, but could progress to needing help with basic things like getting dressed or bathing or grooming. Dementia is not a disease, just like psychosis is not a disease. It's a syndrome, a collection of symptoms that could come along with several different diseases. So dementia is the category. There are medical causes of dementia, thyroid disease, vitamin deficiencies, medication side effects, depression. And there are neurological causes of dementia. The 3 big categories being Alzheimer's, which is about 60 to 70% of cases of neurologically caused dementia, meaning there's mostly short-term memory loss, trouble with keeping track of dates and times, and that there are changes in the temporal lobes right behind our eyeballs, the short-term memory centers. That's Alzheimer's. 10 to 20% of the time, it's Lewy body dementia. And we're going to talk about what that means and the precision of the terminology. But Lewy body dementia could be Parkinson's, or it could be something called dementia with Lewy bodies. We're going to talk about that. And then the least common form of dementia, thankfully, is something called frontotemporal dementia. And that's been in the news a lot lately with Bruce Willis. So last year, Bruce Willis, it was announced publicly that he had aphasia. Aphasia is not a disease, it's a symptom, loss of language. You can have aphasia because you've had a stroke or a brain injury, or you can have aphasia because you have an underlying dementia. And he has a form of frontotemporal dementia. Question here? Yeah.
Yes, on the 60% of the people, is any of it related to gender? Is it gender related, a male more than a female?
Good question. So the question was,
What about age? Is age included in that?
So the question's about that prevalence number, that 60% likelihood of having hallucinations or delusions. Does that depend on the person's age and or gender or any other factors other than the cognitive impairment? It doesn't seem to. Now, Parkinson's is more common in men, period. It's about twice as common in men as it is in women. We don't fully understand why, but it doesn't seem to change the manifestation of the other symptoms so much. But we are looking more into women living with Parkinson's, even though it's less common. They do seem to get more delayed care for their Parkinson's and then less expert care for their Parkinson's. And we're trying to figure out what that is. Is it that women are more likely to outlive their partners, and so there isn't kind of somebody there to back them up? A really interesting point is that the REM sleep behavior disorder, the acting out of dreams, it happens equally in men and women with Parkinson's, and it happens years before anything else comes up. But women's dreams are inherently less violent, so they're not beating up their bed partner. So nobody notices. And we've done videos of women when they're dreaming with their REM sleep behavior disorder, and usually they're like talking and you see their hands kind of going, or they might be like, but they're not like punching and kicking and hitting people. So are people flying under the radar? Are women flying under the radar because their symptoms are maybe less obvious or there's nobody there to notice them? But a really interesting question. And a lot of this goes back to genetics too, right? Are there genetic differences here? We used to tell people that genetic forms of Parkinson's and Lewy body were rare. We're finding many more genes now that increase the risk. They don't necessarily give you Parkinson's, right? There are some forms of genetic changes that will give you Parkinson's. Those are rare. But up to 15% of cases of Parkinson's, we know there are genes that increase or decrease the risk now. And there's probably hundreds of other genes that we haven't found yet.
So is there a good test, particular company that will do the most elegant testing?
In terms of genetic testing?
Yes.
Yeah, that's a tough one.
And
Yeah. I don't recommend the direct-to-consumer genetic testing.
Well, no, okay. Not that one.
No, yes, not 23andMe.
More
or- yes,
scientific.
yes. So we have a neurogenetics clinic at the University of Colorado now. And it is run by one of my colleagues, Emily Forrest, who's also a movement disorder specialist. She started it about a couple years ago now. We have 2 genetic counselors. We have a genetic counseling assistant. We have nurses and social workers. And a lot of the times we can get these genes run for free because there's like research studies, right? So people want the genetic information and they'll pay for it because it's funded by their research studies. So sometimes people will come to me with their 23andMe, most commonly because of the Alzheimer's risk gene, that apolipoprotein E4 or ApoE4, which can increase your risk of Alzheimer's, but doesn't give you Alzheimer's. But the problem is you spit in a tube, you send it off, you get a paper back that says, you're at a higher risk for Alzheimer's. People panic, right? Apolipoprotein E4, about 25% of us have one copy. That about doubles our risk of Alzheimer's in our lifetime. What is our risk of getting Alzheimer's in our lifetime? About 10%, any of us. The older we get, the higher it goes. At the age of 65, it's about a 5% chance of getting Alzheimer's. If you make it to 90, 50%. So almost all dementia in the oldest old is Alzheimer's. There's no plain dementia, right? It's all due to something. So what used to be called senility or senile dementia, it's all Alzheimer's. So instead of the ApoE4 giving us Alzheimer's, instead of that 10% risk in our lifetime, it's about a 20% risk. But the most important thing that we tell people with any genetic information, especially for what are considered neurodegenerative diseases, where brain cells are under additional stress, there's usually the accumulation of an abnormally folded protein building up in the brain, whether it's in plaques or the Lewy bodies or something called tau. The most important thing, whether your DNA puts you at a higher risk or not, is to take care of yourself. So the risk imparted by having one copy of ApoE4 can be completely modified by exercising. So we don't test for ApoE4 in the clinic. Sometimes people come in with their 23andMe and we're like, oh, no. But we tell people, treat yourself, treat your body as if you have ApoE4. Because when they did studies looking at telling people, like if we tell them they're at a higher risk, are they going to quit their jobs? Are they going to move to Mexico? Are they going to divorce their partners, right? Like, what's going to happen? All they did was make their advanced care plans and their wills, which we should all do, and exercise. We should all be doing that. Is there another question? Yeah.
The symptom of psychosis doesn't necessarily mean if you're psychotic that you are also Parkinson's related. There could be an independent symptom, is that true?
Exactly, yeah. So psychosis is the more general term. Hallucinations, delusions, separation from reality. But Parkinson's disease psychosis is psychosis that happens in somebody with Parkinson's. But you can have psychosis because you have a primary psychiatric condition like schizophrenia or really bad depression. You can have it because you're delirious in the hospital, because you're sick with an infection or on medications. But yeah, psychosis just means hallucinations or delusions, separation from reality. Then we have to go, why? Why is it happening? Because that tells us how to take care of it. All right, so dementia with Lewy bodies, DLB, is a form of a Parkinson's-like condition that starts with thinking and memory trouble. They might never have the motor symptoms, slowness, stiffness, shakiness. Often they do, and it's just subtle and they don't notice it, but I notice it because this is my job, this is what I do. But it might never have the motor symptoms. So people that end up having dementia with Lewy bodies, they're coming to my memory clinic, right? They come in or they're dragged in by somebody that loves them, saying there's something wrong with their memory. And then I pick up slowness, stiffness, or shakiness, as opposed to people who start with slowness, stiffness, and shakiness and go to my colleagues in the Movement Disorder Center. And then they screen their memory and maybe there's a little bit of thinking and memory trouble. We used to consider Parkinson's and Lewy body completely separate diseases. If you look at the brain at autopsy under a microscope of somebody with Parkinson's disease with memory trouble and somebody with Lewy body, they look exactly the same. Now, there are those people with Parkinson's, usually very young onset Parkinson's, like in their 30s or 40s or early 50s, who will never get memory trouble, especially if they have a very severe tremor. That seems to be protective against getting other, what we call non-motor symptoms. Thinking and memory, mood changes, orthostatic, bowel and bladder changes, sleep problems. There does seem to be a difference of the younger onset tremor predominant, where they might be at a lower risk. And they're probably different. Their brains do look different. But somebody that gets Parkinson's in their 60s, 70s, 80s, with that higher risk of getting dementia, their brain looks very similar to somebody with Lewy body who started with dementia. So are we doing a disservice to ourselves in research and coming up with new treatments and funding by being separate? Shouldn't we all work together, right? So I work very closely with the Parkinson Association and with the Michael J. Fox Foundation, as well as with the Lewy Body Dementia Association, right? And you'll see the same people at all the same meetings, right? We're all integrated. Let's combine forces here. And a lot of the new clinical trials, including one of a drug called neflamapod, I don't know where they come up with this stuff. It was the Ascend LB trial, which is a medication that helps get rid of the little abnormal proteins that build up into the Lewy bodies. And they took people either with Parkinson's disease with memory trouble or people with Lewy body into that trial.
How's it going?
It was positive results.
Can we get into a trial?
Yes, take my card. Yeah, we'll be starting probably later this summer. Yep, so it was a phase 2A trial, which means it's mostly looking at safety still, but they look, do we see any signal here that things are getting better? It's the first time there's ever been a positive trial for Parkinson's memory or Lewy body. And it's a pill. It's not an infusion like all these other Alzheimer's drugs. Is there a question over here?
Yeah, does diet have anything to do?
Oh, yeah, diet has everything to do with it. So I always harp on exercise first, but that seems to have the best evidence for it. But because everybody in Colorado is already so active and doing such a great job, I trained in Chicago, so like trying to convince people to go outside, period, for like 9 months of the year, or to move their bodies. But after exercise, you're already doing right there, which is 30 minutes, 5 times a week. Like that's the goal of a moderate intensity. You can talk, but you can't sing. A lot of times people will get a little hung up on heart rate, like it looks like a little heart rate. The problem is if you're living with Parkinson's, your heart rate's low. It's not going to go high, so we can't go by that. So by your rate of perceived exertion, you can talk, but you can't sing. 30 minutes, 5 times a week. Anything more than that, sure, we'll take it. But after about like 250, 300 minutes a week of exercise, it's kind of diminishing returns. So 150 seems to be the goal at the bottom, but anything more than 250 a week is probably too much. Not ever yet, but you don't need to. The diet, specifically a Mediterranean style diet, unprocessed, unpackaged, fresh. If it had dirt or eyes on it, you can eat it. If it came out of a factory with 1 million ingredients and never touched God's green earth, don't eat it. You can eat some of it, right? Even like the people that follow the Mediterranean diet strictly, still only do it about 80% of the time. Like your 20% can be the fun stuff. Like you can have tools here and there. 80% should be fresh, unprocessed, unpackaged. And what I tell people is go to the store, like, shop on the ends of the grocery store, right? Don't go in the middle, shop on the ends. Go to the farmer's market in the spring and the summer. Take whatever looks good, vegetable wise, chop it up. Extra virgin olive oil, sea salt, in the oven at a high heat, roast it, put it on top of a whole grain. Delicious. Delicious. I grew up hating Brussels sprouts, right? Like mom used to boil them and they'd be mush and they'd smell terrible. You roast them. Is there another question? What?
Was chocolate too?
Chocolate, well, dark chocolate is actually on the Mediterranean diet. Yeah, dark chocolate, yeah. Is there another question? Yeah.
I wonder why Parkinson's heart rates don't go up.
Yeah, the heart rate is being on the lower side. So one of the other, what can be very bothersome and even unsafe non-motor symptoms in people with Parkinson's is autonomic dysfunction. So the autonomic nervous system, I don't know why they just didn't call it the automatic nervous system, because that's what it is. So it's all of the things our body does without our conscious control. Our blood pressure, our heart rate, our breathing rate, our bowel and bladder function, our temperature regulation, and sweating. When we look at the nerves, the autonomic nerves that go from the brain to your heart and your blood vessels and your bowels, there's also alpha-synuclein in those nerves. Alpha-synuclein is the protein that's in the Lewy bodies. And that's why constipation is one of the first symptoms. That's why drops in blood pressure when you stand up too quick can be an early symptom. But the same with the heart rate variability. So the ability for your heart to go, ooh, she's moving faster. I better hurry up so I can get more blood flowing around. That signal doesn't get through. And that's probably the reason why when you stand up, because if we're sitting or lying down and blood's kind of equal throughout our body, we stand up, gravity pushes the blood down to our feet. And typically what'll happen for any of us is that the heart goes, ooh, she stood up, pump, 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 get it up. Doesn't happen. Blood pools, the brain goes, I'm not getting any blood up here, hello. And it makes you feel faint so that you lie back down. That's why we pass out to lie flat, so that blood doesn't have to fight gravity. The brain doesn't think through, oh, if I make her fall down, she might hit her head, but does what it can. Yeah?
Is it possible for any imaging studies to pick up the presence of Lewy bodies?
Ooh, good question. So imaging for looking for Lewy bodies, not yet, but we're trying. There's been a research grant through the Michael J. Fox Foundation for a long time now to fund studies looking for a tracer, a dye that could be injected that would bind to the alpha-synuclein in the brain. So we do have a dye for Alzheimer's plaques, for amyloid plaques. It exists. No insurance pays for it though. But there have been a few synuclein dyes, tracers that have been developed, but they're just not reliable enough yet. Now a DAT scan, a dopamine transporter scan, doesn't look at the Lewy bodies specifically. What it does is actually a dye that binds to dopamine transporters, so the little cars that move your dopamine around in your brain. And when there's less dopamine, there's less transporters. So the DAT scan just tells me how much dopamine is in your brain, but doesn't tell me why there's less dopamine. Now, the most common reason is that there's a Parkinson's-like condition that is affecting the brain cells that make dopamine. But it doesn't tell me the Lewy bodies specifically. So right now, the only way to visualize Lewy bodies is under a microscope with a piece of brain. So autopsy. We don't pick out any pieces, well, you would miss that. Yes. So this is, I've heard a very helpful breakdown of all the different ways Lewy body is used. And even my own colleagues in neurology and my colleagues even in my subspecialty will use these words incorrectly. But this is the most precise way to use these terms. A Lewy body disease means that there's Lewy bodies in the brain. How do we know that? We have to look under the microscope. But Lewy body diseases, and a Lewy body, it's a little bubble. I don't think I have a picture in this slide set that has a picture of what they look like under the microscope, but they look like a little red bubble. And you dye them with a certain type of stain. But inside that little bubble is sticky protein called alpha-synuclein. We all have alpha-synuclein. Well, we all have synuclein. In some of us, it gets sticky and turns into alpha-synuclein. And then the brain can't get rid of it. It's like, what is this sticky clump in here? I can't, get out. So it puts a little bubble around it. But then the bubble can't get out. And when the brain cell is full of this bubble of junk, it can't do its work and it dies. So Lewy body diseases are either Parkinson's or Lewy body dementia. Now, Parkinson's, starting with slowness, there must be slowness. You might be the shakiest person in the world, but if you're not slow, you don't have Parkinson's. That's why your doctor has you do all these little dance moves. We're seeing how fast you are. If you start with slowness, with or without shakiness and stiffness, but your thinking and memory is totally normal, you have Parkinson's. If at least a year later, You then get thinking and memory trouble. We call you Parkinson's Disease Dementia. And then there's also mild cognitive impairment, right? People don't go to dementia overnight. But you start with Parkinson's, slowness, stiffness, shakiness, then at least a year later, you get memory trouble. As opposed to people that start with thinking and memory trouble. They may never have slowness, stiffness, shakiness. They might get it later. That's dementia with Lewy bodies. I know this is stupid. This is stupid. I have sat in a lot of committee meetings with a lot of other people that have been doing this a lot longer than me. And I said, this is stupid. Why are we doing this to people? This is so confusing. But it's what we're dealing with right now, right? Like, what's a disease? It's what a bunch of doctors in a room decided, like, this is the disease, right? These are the things. And it's always changing. And the dementia with Lewy body criteria last changed in 2017. They'll probably change again soon. But this is the terminology that is currently correct. Questions about this?
Sometimes the first symptoms for either of those two things at the bottom are actually more related to apathy and emotional issues that happen before any Parkinson's symptoms at all, and are in sleep disorder.
Exactly.
Happened years before.
Yes,
Constipation.
prodromal symptoms of Parkinson's
So, I mean,
disease.
when that happens, and then by accident, the first diagnosis was Parkinson's, but in fact, there were all these other
Yes,
symptoms previously, and now it looks like Lewy body.
exactly. So when I'm meeting somebody, I'm figuring out that timeline, right? What did you notice first? And I have to ask those questions, right? Because somebody might have had a runny nose, a clear liquid secretions out of their nose for years. And they saw an allergist and they saw an ENT and they just have a tissue just like stuck up their nose all the time. I'm like, what about this? Oh, that's not really. Are you acting out your dreams? Have you lost your sense of smell? Are you constipated? Are you lightheaded when you stand up? Right. So I'm asking all those questions, not to make either of these diagnoses, but to know if I'm in this category of things. But the prodromal symptoms of the loss of sense of smell, of the runny nose or the drooling, of the acting out of dreams, which is the best clue, because it matches so strongly with one of these. If you act out your dreams, kick, punch, yell, thrash, after the age of around 50. Now, people do this in childhood, like sleepwalking, there's a lot of weird things children and adolescents do in their sleep. But if you start acting out your dreams, maybe even in your 40s, but really the cutoff is kind of 50 and older, you have a 97% chance of having Lewy bodies in your brain. You might never get symptoms. If you live long enough, you would eventually, right? Some people might have to live to 130 before their Lewy bodies started causing trouble. But when people act out their dreams, and if they have an autopsy, 97% of them have Lewy bodies in their brain.
Maybe too early, but are there any studies that show what GBS or DBS would affect that percentage?
In terms of the acting out of dreams?
No, in terms of percentages that you do.
Of psychosis? Very interesting question. Yeah. So one of the major reasons why people are not considered candidates for deep brain stimulation, and the deep brain stimulation surgery right now is to treat the motor symptoms of Parkinson's. Your slowness, your stiffness, or your shakiness. Doesn't help balance so much. It can really help tremor. Even if the medicines didn't help your tremor, deep brain stimulation can. But one of the most common reasons people are told they can't have deep brain stimulation surgery is because they have thinking and memory trouble, with or without psychiatric symptoms. Some people develop new psychosis after they get their deep brain stimulation surgery. Yeah, and it's more likely if there was a little bit, like sometimes like somebody has a little bit of trouble on their memory test, right? But it's like, oh, you know, we think it's worth the risk. They go, and then afterwards they have a lot of other new symptoms that were unintended. Because we still don't even know how deep brain stimulation works. We have no idea. Oh, now, yeah, we'll just stick that thing in there and buzz it a little, see what happens. Because it was a mistake. A neurosurgeon was doing a surgery on somebody living with Parkinson's, and their tremor was continuing through the whole surgery. They were knocked out. They had tremor. The surgeon accidentally nicked a little artery off a little stroke of his subthalamic nucleus, which is where the brain stimulator goes. Trevor stopped. And the surgeon goes, yeah, I meant to do that. Take credit for it. And what we used to do was to go in and do a burn that area of the brain. Michael J. Fox had a Shalimani, they burned that part of his brain to help treat the symptoms. But we don't want to burn people's brains, right, if we don't have to. So the deep brain stimulators came out, first being studied in the 80s and 90s, where if we send a little electrical impulse, can we block some of this activity that seems to be abnormal in here? And it's reversible, you can take the leads out. But the behavioral cognitive symptoms as a side effect of deep brain stimulation, and especially at a university, like they are so cautious. They never want to make somebody worse, right? Because usually the thinking and memory and behavioral symptoms are more bothersome, life limiting, and affecting quality of life for people living with Parkinson's more than their tremor or their slowness of shift. Really good question. Yeah.
Isn't the focused ultrasound treatment burning the brain?
Yes. I was wondering if somebody was going to ask that. Yeah. So focused ultrasound, which has come out over the past few years, is right now used for people who are not good surgical candidates for deep brain stimulation, either because they have bad heart disease or they've had strokes, right? Where being in the operating room would be dangerous for their health. So the focused ultrasound is just like what we used to do in the 80s, but we can do it externally now. We don't have to stick like literally like a hot poker into the brain. That's what they used to do, go burn it. Now the focused ultrasound is a very focused ultrasonic pulse targeted at that part of the brain, and it does burn it internally. So a lot of times people think about focused ultrasound as being non-invasive, right? Like, yeah, you don't got to drill a hole in your skull, but you're burning your brain. And it's irreversible. Once it's burned, it doesn't come back. But deep brain stimulation is reversible. You can take the leads out. Very good question. So, to diagnose dementia with Lewy bodies, there must be dementia. Enough decline in this person's thinking and memory that they are no longer fully independent. Plus, Parkinsonism, slowness, stiffness, shakiness. And usually it's not a lot of shakiness. And it's less of the resting tremor that people with Parkinson's have. It's actually more when they're moving or holding things, but it can be subtle. And sometimes all I see is just a little bit of their thumb, maybe just a little bit of their jaw, but they don't come to me saying, I have a tremor. I pick it up. The visual hallucinations, usually fully formed figures, people or animals. The REM sleep behavior disorder, acting out of dreams. And then cognitive fluctuations, which do seem a little bit more specific for Lewy body than for people with Parkinson's, but people with Parkinson's can get it too. And this is this very dramatic up and down in the person's level of alertness or awareness, or sometimes their psychosis. I've been sitting in a room with people, talking to them, and they're totally with it, you know, telling me a whole story about something, then like a light switch. You see it come over their face, and go, why are you asking me these questions? What do you work for? Right? So sometimes that paranoia or the delusion can come out of nowhere. And then switch flips again. What are we talking about? So every person that comes into my clinic, not only am I asking about acting out their dreams, but I will also ask, we all have good days and bad days. Do you, or does your loved one, seem to have good minutes and bad minutes? Is it like a roller coaster, trying to figure out what version of your loved one you're going to get? Are you getting whiplash trying to keep up? That is extremely sensitive for Lewy body as opposed to something like Alzheimer's or strokes or other things. Because when I ask that question to people with Alzheimer's or their families, they're like, no, not really. When I ask that to people or families with Lewy body, how did you know? So if you have two of these four things, with dementia, and the dementia came first, or at the same time as everything else, you have dementia with Lewy bodies. Now, I can't say definitely without a piece of your brain, but I can say probably. It's the most confident I can be. But all of these things also happen in Parkinson's. So how do we tell the difference between them? What came first? And sometimes in hindsight, it's hard, right? Like to the point of like, well, yeah, things kind of crept up on us and things were coming out and, you know, maybe there was some anxiety, there was the concept, right? But if we can't set very clear time points for when did your body start changing and how it was moving versus when did your thinking and memory start changing, if we can't set clear time points, it's kind of based on what's more bothersome. Why'd you come to the doctor? Did you end up in my memory clinic? It's probably going to be Lewy body. Did you end up in the movement clinic? It's probably going to be Parkinson's. But there is so much gray overlap in between. So in those cases, if there is clear cognitive impairment, if there is dementia, and we can't sort out what came first, then we will use the less specific term, the Lewy body dementia, because it could be either, right? Now, there is literature and information on the internet that dementia with Lewy bodies is a much more rapidly progressive, quick, scary diagnosis than Parkinson's. And we do often tell people living with Parkinson's that their life expectancy isn't really much lower than somebody the same age without Parkinson's. On average, a year younger than somebody the same age without Parkinson's. We used to tell people, good news, you won't die of Parkinson's. Like that's like, thank you, I guess. Your life will be much harder living with Parkinson's. But in terms of Lewy body, on average, from the time people get diagnosed, which usually takes 2 to 3 years to get the right diagnosis, Robin Williams never got the right diagnosis with all the money and fame in the world. And then from the time they're diagnosed to passing away, it's about 4 years. Now, I think that's falsely low. Number one, because we can't diagnose it until they have dementia. There's often years of symptoms before that we're just missing. And then people don't know about it. They've never heard about it. So it takes 3 different doctors on average and 2 years to get your diagnosis of Lewy body. Of course, it's going to look like it goes fast, right? If you're waiting that long.
Yeah, if you knew before the autopsy that a person had Lewy bodies or Parkinson's, would you treat it with them?
Oh, man, you guys are you all readers in here in terms of your questions? Oh, my goodness. So the question was, if you knew it was Parkinson's or Lewy body, would it change what you're doing? Would you do anything differently? No. We take care of people, right? Not labels, like I do. Take care of the person. And so I will often have that conversation with people of, you're not, checking all the boxes perfectly. There are some more tests that we could do. The next question to me is usually, if we do more tests, is it going to change what we're doing? Great question, right? Do we test just for test's sake? No. So I treat whatever symptoms bother the person. And we're going to talk about that in terms of psychosis. If it doesn't bother you, it doesn't bother me, right? I'm going to treat it. If your memory is not bothersome to you and you're living your life, we don't got to treat it. If your tremor is not bothering you and you're living your life, we don't got to treat it, right? So we treat the symptoms, we treat the person, we don't treat the label. But previously, before the Parkinson's world and the Lewy body world were collaborating, there would be research studies for people with Parkinson's, research studies for people with Lewy body, and you can't go to one or the other. But in 2015, they changed the definition of Parkinson's disease. It used to be that if you had dementia at the time you were diagnosed, you can't have Parkinson's. They got rid of that in 2015 because about 15% of people have dementia at the time they're diagnosed, and 80% will get it in their lifetime, right? So the Parkinson's criteria respected that overlap. The Lewy body criteria didn't. And they were updated later in 2017, but they still said, if your motor symptoms come first, 1 year, it's called the 1 year rule. Why 1 year? Again, people sitting in a conference room deciding on things arbitrarily. Motor symptoms for a year, then dementia, Parkinson's. Memory and motor at the same time, or memory first, Lewy body. Doesn't change what we do, but where it comes up is that people read about Lewy body, right? And they read these horror stories on the internet, and so they panic. And I think there is still a lot of misunderstanding and stigma, but where are all those people with the mild Lewy body that maybe they're being treated as Parkinson's or they're being treated as Alzheimer's, right? So I think as we learn more, as we push that needle back and we're diagnosing and catching things earlier, the Lewy body prognosis will look better. And then I also have a lot of people that I work with who technically have dementia with Lewy bodies, but they don't like the name. I don't like it either, right? Dementia, front and center. Alzheimer's is Alzheimer's, Parkinson's is Parkinson's. You got to put dementia first. So they'll say, like, is it okay if I tell my friends that I have Parkinson's? Yeah, you have Parkinson's technically. You meet those criteria too. And then a lot of people just say Lewy body, like Lewy. I'll use Lewy body. And then people are like, who's Lewy? Right? Like, L-E-W-Y. Yeah. Frederick Lewy was an Austrian neuropathologist who escaped Nazi Germany. But I also dislike the word. Now, the counter argument is, well, dementia, we should destigmatize that too, right? Just like we're destigmatizing psychosis. You can live a great life with dementia. But I understand the hesitancy to stick any label on anybody. All right, so we've already kind of covered this a bit, but what are we talking about in terms of what people are actually experiencing with these things? So hallucinations. It is the presence of an environmental stimulus that you feel that nobody else does. Now, most people think automatically about visual hallucinations, people, animals, bugs, whatever it is. And those are the most common ones in Lewy body. But any sensory modality can experience a hallucination. So you can hear things, taste things, smell things, feel things. Visual are most common in people with Parkinson's and Lewy body. Like I said, they're usually fully formed, but sometimes they're more subtle and mild. Sometimes your brain misinterprets something that is there. Just like that picture we saw at the beginning, that was done on purpose to trick our brains. But sometimes people with Parkinson's will have visual illusions, which is there is something there. I'm not making something out of nothing, but my brain's misinterpreting it. So the common things we hear, you see the floor lamp in the corner, that person over there, busy patterns in the carpet or upholstery, and you see faces or other things emerging from it, faces especially. But often we can also hear about auditory hearing hallucinations. They are different than the hallucinations we see in people with primary psychiatric disorders like schizophrenia, where it's not, usually in schizophrenia, it's a voice that's either telling the person to do something or saying really mean things to that person. Usually that's not what we see in Parkinson's and Lewy body. Usually it's more just like snippets of either songs or conversations, or you think you hear footsteps on the stairs. Oftentimes we'll hear, it's my neighbors are being so loud over there. And the partner's like, I don't hear anything. But it's not like words that you can interpret or somebody telling you something specifically. But again, we all get that too, right? Earworms, right? There's those songs that get stuck in our head and we, like, is somebody playing music, right? Like, stuck there. The brain does this. Just happens more to people with Parkinson's and Lewy body. On the most mild end of the spectrum of hallucinations are feeling a presence, that somebody's right behind you or with you, somebody else in this room, or passage hallucinations out of the corner of your eye. Did somebody just walk by, or did a little bug just, run by over there? And we all do this, especially in low light situations. The brain is more likely to fill in the blanks, but it happens more to people with Parkinson's and Lewy body. So in terms of those illusions where the brain sees something or hears or feels or tastes something and it kind of misinterprets it, our brain does this. How many people see a duck? Raise your hand. How many people see a rabbit? Did the people who saw the duck see the rabbit now? Can you make it switch back and forth? Yeah. Yeah, our brain does this, right? It tries to make sense out of randomness or somewhat more less specific or things that can be interpreted in different ways, right? And it's a survival mechanism. Is that thing dangerous? It's going to eat me, right? So the brain has to think through all the possibilities. A specific form of a visual illusion is something called Peridolia. Peridolia is seeing faces in non-faces. And this is an extremely deeply evolutionarily embedded thing in us as human beings. Babies, newborn babies, right after birth, attend to things that look like faces. Because again, it's important. We are social animals. I better look for things that look like human faces because they'll take care of me. They'll keep me safe, right? So just some examples of things like, I mean, none of these things were made to look like faces, right? But our brain sees faces there. It's normal human phenomena. Just happens more to people with Parkinson's and Lewy body. We can test for this in the clinic. This is something called the noise Peridolia test. It was developed in Japan. The Japanese are running circles around us in terms of research lately, and they have so many great tests for Parkinson's and Lewy body that we don't have here that aren't FDA approved. But what we do is we show 40 of these ink blot cards, and this is not like Freudian, tell me about your mom and things like that. This is to see if your brain sees faces where there are none. So this is an example where there's a face, right? Up in the right corner, there's a face there. There's no face on this one. And we go through some examples, right? Because people will often get very anxious in their clinic and they're like, okay, I'm gonna do a really good job. And I'm like, I'm gonna find all these faces. And it's like, no, some might not have faces. But what I'll hear when I show these things to people with Lewy body is like, oh yeah, no, I see a face, I see a guy with little eyes up there. And oh yeah, maybe there's another little face here. It looks like little Winnie the Pooh in there. They'll tell me all these stories. And it's like, no face there. Again, the face should be obvious, relatively obvious. But people with Parkinson's and Lewy body will see faces in randomness.
Now, you just said, I don't know if I'm pronouncing it right.
Peridolia, yes.
It's more prevalent, the quantity in person that has Parkinson's. What is the critique? What is the metric when you said more? Is it 20% of the time?
Oh, that I don't know the exact numbers, right? Because unless you look for the Peridolia,
Yeah.
right? And again, we all do it. But the way that we can objectively measure it is through these kinds of tests, right? So if we showed these 40 cards to 100 people with Parkinson's and these 40 cards to 100 people without Parkinson's, how many faces do they see on non-face cards?
Oh, that's the quantity.
Yeah. And so out of these 40 cards, if you see a face on 3 or more cards on which there's no face, the likelihood that you have Parkinson's or Lewy body is about 90%.
That is so scary.
Right? Right?
I don't know why.
Because it's a little fluffy, right? So this is what I do as a thinking and memory doctor, right? Like I'm not just focused on what we can see in how the body's moving. I do all these other little things, right? It's not that people don't want to do them. Oftentimes they just don't know these things exist or they don't have the time to do them. But like I just keep this on a file on my computer in my office, right? And then I just open the PDF and I'm like, face, no face, face, no face, right? I have the luxury being at the university that I get 90 minutes with my patients. Most doctors don't get that.
So when you're about to show this cards to patients, do you give them any kind of information up front as potentially how many faces are in the deck, whether there's no faces in the deck, you don't prep them at all?
Well, there are instructions, yeah. So for every single neuropsychological test, of which this is one, you have a very clear script you have to give to people, right? Because if you don't give the prompts in a very specific way, the test might not be valid. So the prompt for this test is, I'm going to show you a series of ink blot cards. Some of these cards have faces on them. Some of them will not. I want you to tell me if there is a face or not. Don't think too hard about it. The face should be obvious. Because again, you'll get people who are like, oh my God, there's got to be a face here, right? So I say some might not have faces. They should be obvious. And then I have face or no face. And it can't be like, no, face or no face, face or no face, face or no face. So hallucinations are seeing, hearing, feeling, tasting, touching something that is not really there. Or at least nobody else, right? Our sense of reality is what we all agree on. Nobody else sees, feels, hears, tastes, touch. A delusion, which is the other main feature of psychosis, is a false fixed belief that the brain is absolutely convinced of, even if there is a ton of evidence to the contrary. These are usually paranoid. Somebody's stealing from me, my partner's cheating on me, somebody's trying to break into the house, somebody's watching us. I hear that one a lot. And oftentimes there's a kernel of truth to it. Like there's something that tipped the brain off, but then the brain just ran with it. For example, I worked with somebody who their neighbor had a clog in their plumbing, and they had to like rip up the whole street and like get the clog out of the plumbing. And a few months later, he developed a delusion that if he ate, he would have bowel movements that would block their plumbing. So he stopped eating. He lost about 100 pounds before he got to me. And he could not, and the family was like, no, it's fine. Like, it's fine. Like, you can eat, we'll figure it out. Like, it won't happen to us. We couldn't convince him, right? The most common ones that we hear usually also go along with the kind of sundowning phenomenon in the evenings. Now, sundowning is not actually a true medical term, but we all know it when we see it, right? And it's probably related to the fact that there's less light, less ambient light, more ability for the brain to fill in the blanks. And also at the end of the day, people are tired, right? Even if they didn't do too much that day, we start shutting down. And so other parts of the brain might start peeping up in terms of things that aren't really true. The delusion that this is not our house. Looks exactly like our house. I know this is my stuff. It's not our house. Please take me to our real house. I know you look exactly like my wife. You're not my wife. You're an identical imposter. So those are both delusions. The first one's called reduplicative paramnesia. You don't have to know that, but it's a thing. Second one's called Capgras phenomenon, an identical imposter. Yeah.
Does it also include time shifts?
How so?
An individual suddenly 20 years.
Oh, yeah, yeah. Mm-hmm. Yeah, and that's an interesting one. And where the border is between what's a hallucination or a delusion and what's a false memory. Because oftentimes we'll hear like, oh no, well, mom was just here. Like I had dinner with mom today. Yeah, mom's been dead for 20 years. No, she was here. Did she see mom? Like was mom at the table with her? Or is she just unmoored in her timeline? So those situations where we're trying to sort out, did you actually experience something? Are you fully convinced that it was happening? Or are you just a little bit off on your timeline? That can be really hard. And trying to get somebody to like, because like they don't remember what was happening, and trying to get them to explain it. And like their family's like, well, this is what happened. We're trying, like, this is what we were seeing. We were trying to figure it out. But it's not necessarily a hallucination or a delusion. But if somebody is absolutely convinced of something, and on the whole, don't argue, right? Don't try to convince somebody it's not their fault. But usually the degree of distress with this delusion, as opposed to a timeline shift, I like that term. Usually they're not distressed about it. They're like, yeah, mom was here. It's like, no, she wasn't. It's like, oh, maybe I'm wrong, right? As opposed to, mom was here. We were having dinner. Yeah. She's right there. She's there. Yeah. But it can be shades of gray, for sure. Yeah. We talked about this. So, any questions about what things can appear like, how they can manifest in people, how we term them, things to look out for?
How about just a little comment on how intense this can all become? I have a partner who has delusion, psychosis, hallucinations all day long, every day for years now.
Well,
And so, I mean, that might be an extreme.
Yeah.
I don't know. We've tried all the anti-covenants.
yeah. So these symptoms, the psychosis
I
symptoms,
think we need to see you.
yeah, I'll get my card. Especially the delusions are the most distressing and negative factors for quality of life, more than anything else. And it seems it's related to the fact that those delusions are attacking the integrity of the relationship. I've been taking care of you, and you're accusing me of cheating on you? So there's something so personal and devastating for those types of things. Like a tremor, okay, fine, we'll work on the tremor, right? But it's not inherent to your identity as a person or in your relationship. And even though these non-motor symptoms, including the psychiatric symptoms, are so devastating, we have so many fewer options for treating them. And there's way fewer research studies, way fewer research grants going towards it. Yeah.
During the hallucinations, how real, how long-lasting are they? Doing something in the home and seeing something that's not there and taking an action, or driving and seeing something that's not there. Does it last a moment, or does it last a long time?
And it depends, yeah. Sometimes it's just like even the quick little ones, right? It's like, ooh, there's somebody dead, right? And the most mild then, there can be months of sustained hallucinations or delusions. And we don't know why. Some people only get a little bit, some people get more. It does seem like they're worse the more cognitive impairment the person also has in terms of that kind of reality checking, right? Of like, all right, I see mom standing in the corner over there. I know mom is dead. So therefore she can't really be there. I'm going to ask my partner, do you see mom over there, right? And when there's that retained insight of I know this can't be real, then they go away. And we'll talk about some tips and tricks for people that do have the insight as opposed to how you have to manage it for somebody that doesn't have the insight. But they can be seconds, they can be months.
I'm thinking specifically of someone driving.
In terms of they like saw something on the side of the road or?
Seeing something and reacting.
Oh.
They're while driving.
Yeah.
Get out of the car.
Yeah. In terms of like if there were another car close by or like a stoplight or thing. Yeah, that's a really interesting point. And it kind of feeds into why do people with Parkinson's and Lewy body have visual hallucinations at all? Why? Why does this happen? And again, like we all get a little bit, but like we're not seeing fully formed people or animals, right? And how does this relate to the other cognitive changes in people with Parkinson's and Lewy body? Where, like I said before, people with Parkinson's dementia look very different than people with Alzheimer's dementia. They have some forgetfulness and short-term memory loss, but not to the degree of people with Alzheimer's. They don't lose pieces of themselves or their autobiography. They don't forget their loved ones. But they have a lot of changes in what's called executive functioning, planning, multitasking, following multiple steps, making decisions, and visual-spatial function. Spatial relationships, how things fit together. I hear a lot that people take things apart, then they can't put it back together, and everything's in pieces, and their families are done. So those executive and visual spatial changes are also directly related to our reality check. How also do the vivid dreams that play into acting out our dreams, right? It's all visually based. In terms of driving, which is always a sore subject. Here in Colorado, not a mandated reporting state, right? I don't call the DMV unless I'm afraid you're going to hurt somebody or yourself. When I practice in Chicago, when I practice in New York, I call it DMV on everybody. Everybody hates me. But here, I don't get sued. You get sued, right? So it is my job to keep you safe. We have driving safety evaluations at the university. Our occupational therapists can do them, and Medicare pays for it. We worked this out a few years ago because there are private companies that'll do it. It costs like $300-400, which, like in the grand scheme of things, right, it saves you, a heartache down the road. But our occupational therapists can do them. Put a referral to occupational therapy if you have any. I don't you have to have a referral from the university. I think external providers can refer into the occupational therapy, just put driving safety evaluation. And they test your reaction time, your field of view, your processing speed, and they'll give you a report of your safety. It's not like a legally binding document, but if anything were to happen and you were deemed safe, you're protected, in theory, right? And lawyers can always work the system, but if there's any issues on that occupational therapy assessment, they will often recommend an on-the-road test. That's kind of like a final arbiter, but then you gotta pay out. So anybody living with Parkinson's, even if they don't have thinking and memory trouble, can have changes in their reaction times and processing speeds, right? So because Colorado is not a mandated reporting state, it kind of rests on the person to keep themselves and their assets and their family safe, because drivers are insane. I am a native New Yorker. People do stuff on the road here I have never seen. And so I am almost never worried about the person I'm working with. Well, sometimes I'm worried about the person I'm working with, but I'm worried about the other nuts on the road doing something unsafe around them. Think, this guy's got Parkinson's, it's his fault, right? So do your due diligence, do the safety evaluation. But I have heard, and sometimes it's the very first symptom. I've had a few people come to me that way, where they were driving, often late at night, and they saw a hitchhiker on the side of the road, or they were worried they hit somebody on the road. But I'll often hear driving otherwise when somebody else is in the car with you. And the best indicator of driving safety and likelihood of an accident is if your passenger feels safe in the car. That's it. They've done study after study after study. Now, that's not an objective measure, right? So if you're in an accident, can't be like, well, my wife said I was okay, right? You got to still do the driving safety evaluation. But if somebody says to me, I feel safe in the car with them, I'm less concerned. But if I hear, our daughter won't let the grandkids in the car with them, right? Red flag, right? But in terms of how the brain is interpreting visual information, depth perception and spatial relationships, where people with Parkinson's might misinterpret where the lanes of the road or the other cars, where the stop lines are. It's not their fault. Their brain's just giving them the wrong information. And that's different from, there's a car there, I see it, and everybody else is like, I don't see a car. So that's the difference.
Where does speech, impacted speech, play out in the symptoms?
Mm-hmm. So there's a difference between speech and language. And speech is the motor production of the sounds, and language are the actual words. Thinking of the words, the right words, understanding the words. And they're related, absolutely, but they're a little different. And usually people with Parkinson's have no trouble with their language. The words are in there. Might take them a while to get it. They get that tip of the tongue, where it's like, you know the thing, you know the thing. And a very common thing in people with Parkinson's that's mistaken for dementia is something called bradyphrenia, slow thought. So bradykinesia is slow movement, which is the hallmark of Parkinson's. They can also have bradyphrenia. They don't have dementia, we just gotta give them long enough. And the number of people that have been sent to me as Parkinson's dementia, and I sit with them, and we take like an hour to do their memory test, just fine. So nobody just gave them enough time to give me the right answers. But usually their language is normal. And that's another clue we use when we're trying to separate Parkinson's and Lewy body from things like Alzheimer's. They understand just fine, they speak just fine, but the words are soft. They might be a little slurred. And the softness of the speech, when the reminder about fatigue, big and loud, right? The principles are the same for moving and for speaking, because it's the same underlying problem. Things are slow, they're not as automatic and easy and fluid as they should be. So it takes more energy to do things that used to just be automatic. And that's why the voice trails off the longer you go. It's why your handwriting trails off the longer you go. It's why when we have you do all your little dance moves, they trail off the longer you go. Because that sustained automaticity of those motor behaviors is lost. And it's also why most people, up to 100% of people living with Parkinson's, have fatigue. They're exhausted. Because it's taking so much energy and effort for their body to do things that just should be automatic. Does that answer your question? Okay. All right, so in terms of what hallucinations and delusions are, making sure we're noticing them, making sure we're bringing it to medical professionals' attention. We know it's there. What do we do about it? The first step to doing anything is knowing why it's happening. Somebody with Parkinson's or Lewy body is still vulnerable to other medical conditions. Just because you have Parkinson's doesn't mean you can't get other things. Right? It's not. It is. It's bullshit, right? Yeah. you should get a pass for everything else, right? I agree with you. Because it also doesn't protect you against Alzheimer's. You can have both. That's really unfair. So, before writing things off as, oh, it's just part of your Parkinson's, making sure we're not missing anything else. Right? The most common cause outside of the disease itself are medications. The problem is, a lot of the medicines we use to treat your motor symptoms also cause psychosis. So for me, as primarily a memory specialist, seeing people who already have thinking and memory problems, that's why they're seeing me in the first place, being at a much higher risk of getting hallucinations or delusions, I'm not going to use a lot of these Parkinson's medicines, period. Somebody that's young, healthy, no memory trouble, you have your pick of all the Parkinson's medicines, right? Never say never, everybody can get side effects, but the side effects are less likely. The Parkinson's medicines that have the highest risk of causing hallucinations or delusions, amantadine. Amantadine is what's used for the dyskinesias. You've been on your levodopa, it's working okay for you, you start getting too much movement, you overshoot. So a lot of movement disorder specialists will then add on amantadine. The number one side effect of amantadine is psychosis. It can also cause a rash, a blue lacy rash on your legs called livedo reticularis, where you can kind of see your little capillaries in your veins on your legs. I never use amantadine. My patients are very different from other movement disorder clinics. But the first thing I'm doing, if a patient with Parkinson's is having hallucinations or delusions, is checking their medication list. What can we get rid of? Because it is always better to treat a symptom by getting rid of something than by adding something else to it. Never treat a side effect of a medicine with another medicine. And sometimes we're stuck, right? Like sometimes we need that dose of the Parkinson's medicines to allow you to move and live your life. And so then we have to find the balance, right? Sometimes we will add an extra medicine. But if we can get rid of something, get rid of it. Artane or trihexyphenidyl is a very old medication. It's anticholinergic, meaning it blocks a chemical called acetylcholine, which is actually the chemical that's required for your memory formation. And all of our memory medicines increase acetylcholine. So if you are on trihexyphenidyl, not only can you have thinking and memory trouble, but you can also have psychosis. So I also never use that. And then the dopamine agonists, ropinirole, pramipexole, rotigotine. They can also cause psychosis. This is in decreasing order of likelihood. So the amantadine and the trihexyphenidyl most likely, dopamine agonist less likely. Levodopa, Sinemet can also cause or worsen hallucinations. It's less likely to do it than the others, but it still can. So the first thing is look at the list. What can we get rid of? What can we lower? Separate from Parkinson's medicines, though, there are even over-the-counter medicines that can cause psychosis. The most common one is Benadryl. Diphenhydramine. You can buy it over the counter. You can take 6 or 7 of them. Oh, I'm just treating my allergies. Tylenol PM, Advil PM. It's all Benadryl. Never take Benadryl. Nobody should take Benadryl unless they're having an anaphylactic reaction. Non-drowsy allergy medicines, Claritin, Zyrtec, Electric, fine. Benadryl increases the risk of dementia. Go ahead.
Where should I sit?
That was your very good point. Yeah. So the bladder medicines. I don't even have those on here. Man, this is chat with the pros on both sides here. The overactive bladder medicines are also anticholinergic, just like Artane and just like Benadryl. The older ones, so Ditropan, I forget the brand names of these. Basically, any overactive bladder medicine that is not Myrbetriq or Sanctura can cause confusion, hallucinations. So the urologist will often start one of the overactive bladder medicines, and then they come and see me, and I'm like, oh no. The problem is Myrbetriq and Sanctura are expensive.
Say those two again, because those are acceptable, correct?
Yes, Myrbetriq, Myrbetriq.
Yeah.
Thank you. Ding. Sanctura is Sanctura. I was not in the spelling bee, if you could tell.
Melatonin.
Melatonin's fine. Melatonin's fine, yeah. But I have a lot of people say, oh, melatonin doesn't work, right? So I have to take my Tylenol PM. Like, no. Melatonin doesn't work like sedatives do. So melatonin just tells our brain, hey, it's time to get ready for bed. It doesn't put us to sleep though, but it helps set up a normal sleep-wake cycle. And it also helps with the apnea of dreams. Sleep aids, Ambien, Lunesta, Tylenol PM, almost none of them actually make us sleep better. On average, you get to sleep like 7 minutes faster. And all they do are cause problems. Trazodone is a prescription medicine that I feel safer with. It's an old antidepressant. It can help with sleep if we've really tried everything else. Mirtazapine is also an older antidepressant that can help with sleep. It's relatively safe, but I try to do everything I can without pills. The single most effective way to get good sleep, go to bed and wake up at the same time every day, no matter what. No matter what. Figure out how much sleep you want. Figure out what time you want to be up in the morning. Count backwards for your bedtime. After about a month of doing that, even if you get in bed at 10 and you're staring at the ceiling for a while, after a month, your brain will start going, oh, she's going to go to bed at 10, so I'm going to start getting ready. And she's going to wake up at 6, so I better get my sleep in. And it's not, oh, I was up looking at the clock all night, now it's 6, I'm just going to go back to bed. Out of that bed. If you do that for a month, I promise you, you will sleep better. Now, Parkinson's throws a wrench into that because people don't get into deep sleep as much. Their sleep is fragmented. So their sleep's a little bit different, and that's where the melatonin helps. It gets them more into deeper sleep. Another thing that can be very effective for sleep, as well as for confusion and the hallucinations and delusions in the evening, is bright light exposure. First thing in the morning, have your coffee on the porch. We have beautiful sunshine here in Colorado. If it's not a sunny day or you don't have access to the outdoors, buy a SAD lamp. Seasonal affective disorder, SAD lamp. So when people get depression, when it's dark and there's not as much sunlight, you can buy them on Amazon. They're about $30. It's a 12 by 12 light box. It does not have any UV light. Please make sure no UV light so you're not frying your eyeballs. You put it on the table while you're having your breakfast, you're reading the paper, about a foot away. You start with about 10 minutes every morning. You can work up to a full hour. Bright light is better at natural light if you can get it. And then another session of bright light therapy in the early evening. And you would think that would be kind of counterproductive, right? Where it's like, ooh, it's going to turn my brain on if I'm trying to go to sleep. So it turns down your brain's natural melatonin in the early evening, which is more alerting, right, for that time when you're trying to avoid the confusion or the sundowning. And then as it's turned down, you get a bigger peak at bedtime. Light, light, light. Anything we can do without pills. The other one on here are the antibiotics. Now, anytime I hear that somebody is suddenly more confused, my first question is, what else changed? Do they have any other symptoms? Do they have a urinary tract infection? Do they have a cold? Did they start any medicines recently? Did they stop any medicines recently? Are they in pain? Are they constipated? How have they been sleeping? Because for any of us, any of those things are going to throw our brain for a loop. But if somebody's already living with a neurological condition, it's going to throw their brain even more for a loop. So look for those explanations for a sudden confusion or delirium, which can come with hallucinations or delusions. But sometimes the treatment, if it's an infection, can also cause some confusion, right? So I always warn people. I was just on the phone with family yesterday. We found the UTI. Yep, that's why he's more confused. He's on antibiotics for 3 days. Let me just warn you, he might still be confused for these next few days. It's not because we were wrong. It's just because the antibiotics can also stress his brain. So give a few days to finish his antibiotics, let it clear. If he doesn't clear after the few days later, then we got to go back to the drawing board. Right. So we checked, we made sure we're not doing it to the person, or there isn't an easy explanation with something else going on in their body or their environment. It seems to be just the Parkinson's or the Lewy body that's causing the hallucinations or the delusions. Now what do we do? The first question is, does it bother you? A lot of people skip that step. I've seen a lot of people put on medications just because there were hallucinations present. They weren't scary, they weren't distressing, they weren't acting on it unsafely. They're just like, oh, yeah, no. I see a tiny purple rhinoceros over there. That's weird. Right? Yeah. You don't need a medicine for that. One of my favorite patients recently passed away. His hallucination was topless women. The first day I met him and his daughter said, don't you dare take them away. Again, doesn't bother you, doesn't bother me. You don't have to treat that, right? Is it bothersome? Is it distressing? Is it scary? Is it making you do anything unsafe, right? I've had people where they're convinced there's people in the living room, they're having a party, they won't leave. He brought the hose inside, hose down the whole living room, right? Calling the cops is a big one. You know, somebody's trying to break into the house or there's somebody in the house. So again, but what can we do otherwise without medicines to prevent that? Even if it's unsafe or bothersome, you still try to do what you can without extra pills. The easiest thing is making the environment less prone to creating tricks for that brain. If there's a floor lamp in the living room that the person always thinks is a person in the corner, get rid of the floor lamp. I had a person who would not go into her living room, her formal living room, and once we figured out it was because the floral pattern on her couch, she would see things emerging from it. So we put a slip cover on the couch, right? Like common sense stuff. And your doctor and other health professionals, like we can kind of troubleshoot, right? And crowdsource. And that's another thing that comes up usually in like message boards or support groups where it's like, oh, yeah, I had that and we found that this helped, right? Like, so any of those little tips and tricks and problem solving and troubleshooting, finding a way to get rid of anything that's bothersome or unsafe before starting pills. Something I've heard from people, especially when there's some insight, or again, it's like, I know mom's not here, but I see she's right there, it's here. Trying to talk to it or interact with it, or kind of changing the perspective, the viewpoint, which most easily can be done with a flashlight. So one of those like really bright mag light flashlights, kind of like shining it, and then the brain, it changes how the brain's seeing, and sometimes poof, just disappears. Right, so these little kind of things, and not everything works for everybody, and it's a lot of trial and error. But anything we can do to keep that brain safe with as few medicines as possible. Does anybody have any other like tips or tricks? Yeah.
Not necessarily a tip or a trick. My mom often sees like blankets and assumes that they're
Like a pile, like an animal curled up or a pile like that.
so all I have to do is just smooth the blanket and it makes a huge difference.
Yeah.
But I do have a question when we're talking about medications. You're removing a bunch. Are there any to add in, like vitamin Bs or, you know, This lion's mane I keep hearing about. So you have set me up for my next slide. The question was, yes, we get rid of everything we can. We do everything we can without pills. What if that doesn't work? What if we're stuck? Now, in terms of vitamins and supplements overall, there is no good evidence for any vitamin or supplement right now for treating neurodegenerative diseases. There have been some studies, B vitamins, C, CoQ10. The lion's mane's a newer one. I don't think there's been any randomized controlled trials. And ashwagandha is another one I'm hearing a lot about lately. And then cannabis. We just got a large grant to study cannabis and people with Alzheimer's at the university. So we're trying to answer the question, right? Yeah, please. And now psilocybin, right? So psilocybin was decriminalized in Denver and it's kind of exploded in terms of interest, not only for psychiatric conditions, but also neurological conditions. So right now I can't use any evidence base, like I don't have anything to make recommendations on vitamins. The exception is vitamin B12. B12 deficiency can absolutely cause stress on the brain, can cause thinking and memory trouble, can cause psychiatric symptoms, can cause nerve damage, and can damage your spinal cord too if it goes long enough. So we always check vitamin B12, we always check thyroid. There have been more studies recently on vitamin D in terms of brain health overall. And there's always been a long history of vitamin D in terms of multiple sclerosis. So the further away you live from the equator, the higher your risk of multiple sclerosis. Right? Totally, right? Yeah. So they've done trials, like give people living with MS super high doses of vitamin D. Doesn't seem to do anything. But there was just a big study that came out looking at every single Medicare recipient. Anybody on Medicare is probably in this study, de-identified. They don't know who you are. They just pull all the data for everybody that has Medicare. And they followed for 10 years people who were taking extra vitamin D versus people who were not. There was about a 30% lower risk of developing dementia in the people that were taking extra vitamin D. Right? It's a retrospective study. We can't prove cause and effect. You know, were people taking D, you know, doing anything else healthier for their body or their brain? Was it just people who were told to take D? Were the people taking, you know, so a lot of other questions, but vitamin D is safe, right? Vitamin B12 is safe. So on the whole, I tell people exercise and get all your essential vitamins and nutrients from a colorful, fresh, unpackaged, unprocessed diet. Our body processes those things much better than the mega doses that are in vitamins. Instead of taking fish oil, just eat fish. Americans have the most expensive urine in the world. All the vitamins go, like 99% of the vitamins go through us. So most vitamins, if it's one thing, if it's B12, if it's D, if it's one thing, it's probably okay. Where you get into trouble are these kind of proprietary blends of things that cost an arm and a leg, and they're making huge promises without any data. Prevagen. There's no evidence for any of those things. There is very good evidence for a Mediterranean diet. If you have a vitamin deficiency, treat the vitamin deficiency, but it's hard to tell with extras otherwise.
Thank you. I'd like to focus on this interacting with the hallucinations.
Yeah.
Paradoxically, people are seeking out, certainly in Colorado, hallucinatory drug medications for a greater sense of awareness, enhancing their creative skills, etc. and so forth, harnessing the attributes of what is not necessarily pathological, but maybe a very special stage in a person's life, artistically being able to express what these hallucinations are about, or even writing about them. The efficacy of the artistic aspects of seeing it more of an attribute, less
Seeing
than
the positive.
pathological dimension.
Want to learn anything? You want to say together? There have been a few studies of using art therapy for the hallucinations, and there are paintings and drawings of people's hallucinations, and that it does seem therapeutic. And then there's also been studies on people who were artists to start with, and seeing how their art changed, even prodromally. So like they developed Parkinson's or Alzheimer's or Lewy body here, and looking back at their art production and how it changed and seeing little clues there that maybe there was something changing in how their brain was interpreting information. But absolutely, you know, we pathologicalize everything, right? It's like, this is bad, this is abnormal, don't do this, right? But sometimes things can bring other creativity and beauty into the world.
In the spiritual domain.
Exactly.
Spiritual domain.
Exactly.
Understand.
Yeah. You know, in terms of, you know, all the saints, right? The saints who were talking to, you know, God or Virgin Mary, right? Like, were those hallucinations, right? Where do we draw the line between what's, I always put normal in quotes. There's no such thing as normal. We're all weird, just weird in our own ways. But where's that dividing line to what's a disease or what's a problem that needs to be dealt with? I mean, think about autism. I mean, how long did we go trying to cure autism? Where instead, if we just appreciate their brains for how they are and give them the supports and the resources that allow them to be successful, how much more do we gain out of them, right? So it's more of the spectrum and the rainbow of human behaviors and experiences, and that we don't necessarily have to stick the label of wrong or bad or abnormal on people. Absolutely. Yeah.
I thought I heard, maybe you can confirm, early on, you said talking about an hallucination is beneficial.
It can be, it depends.
But anyway, they should, if someone has.
Oh, yeah, yes, we should definitely let the doctors know, yeah, because number one, it could change how we're taking care of the other symptoms, if there's certain medicines we need to look out for, or infections or things we need to. What we don't want to happen is what happened to Robin Williams, right? Robin Williams was hallucinating, he didn't tell anybody. Number one, that led to the wrong diagnosis. Number two, they didn't treat him appropriately, and he was extremely paranoid in his final weeks and days of life, and led to him taking his own life.
What I was getting at is, on a day-to-day basis, if someone has a kind of hallucination, so they can turn to their partner and say, I'm seeing something over there.
Yeah, if they feel comfortable with it, right? Yeah, yeah, and again, bringing down that stigma of, yeah, our brains kind of play tricks on us sometimes. Like, I want us to have an open, honest, loving communication where you don't have to feel embarrassed or like you're, you know, like I'm going to think any less of you. I'm not going to bring you, you know, and lock you up in a padded cell when you tell me these things, right? So the more open and comfortable and inviting and safe somebody feels, the better overall.
I would just follow up with the gentleman's observation. Very caution in engaging people who are experiencing social psychosis.
Yeah.
I've also seen a reaction of anger on the part of the person who's experiencing the psychosis. And so it might be beneficial in some cases, but in other cases, it can be destructive. It can elicit a form of destruction.
It definitely takes some trial and error, yeah, to find the right communication and reassurance. Now, where the anger usually comes from is a contradiction, right? So if somebody doesn't have insight, if they're not saying like, do you see that over there? If they're like, this is there, see it? Like, you're lying to me. Do so, yeah, get them out, yeah. So with that person, you're not gonna convince them. Because not only are they hallucinating, they also have a delusion. So the brain is not gonna be convinced. So in those cases where you are not going to be able to change that person's mind, and it's just escalating and the person's getting upset, distraction. So first of all, validation, like, I'm so sorry. That's how, I understand you're seeing that. I'm sorry. Can you help me with this? People living with cognitive impairment, whether it's Parkinson's or not, a lot of the behavioral symptoms, the sundowning, the agitation, comes from feeling unproductive and non-contributing to the household. So that energy and the skills that they use their entire life to contribute to their household and their relationship have nowhere to go. So for people that are more impaired, that do not have that insight, who are getting a little bit more agitated or upset in the evenings, whether they're hallucinating or not, having some tasks that are repetitive, simple, soothing. The brain loves routine, loves repeating. The brain loves to sort stuff. So I will often recommend to families to have big laundry basket, different colored socks, different sizes, different shapes, you know, that they're very obviously different. Can you help me with the laundry? Like, I'm so overwhelmed with the laundry right now. Here's a laundry basket. Now, if they never did laundry and they hate laundry, that's not the right option for them, right? Instead, you know, here are all the bills, right? All the junk mail, right? Can you help me sort these bills, you know, based on, you know, the color or the shape, right? Like finding a way to have them able to contribute to the household where they feel included and like they're contributing, and distracting them from these things that are going to happen when the brain's not otherwise occupied. Go ahead.
Hi, I was wondering if you've seen any correlation between Parkinson's and
Correlation between Parkinson's and addiction. That's a very interesting question because it's usually a negative correlation initially. So there are some studies showing that people with Parkinson's have a certain personality. They are usually type A, kind of rigid in their thinking. They like things a certain way. They like organization. I'm hearing some chuckles. A lot of engineers who like rules and routines, and they are very risk averse. So sometimes you'll see study, and I'm not making generalizations, like everybody's different, everybody's brains are different, but we see these patterns. And every once in a while, you'll see a study that says smoking protects you against Parkinson's. Like every time that's on the news, we're like, please don't. No. Correlation does not equal causation. People who are at risk of getting Parkinson's in their lifetime were never going to smoke anyway. They were risk averse. Now, how this is related to dopamine levels in our brain, period. So that's what causes Parkinson's, right? The cells that make dopamine in our midbrain and the substantia nigra, they start dying. Once we've lost about 50% of those brain cells, the levels of the dopamine drop to a threshold where our body now has trouble doing what it needs to do by listening to our brain. Dopamine allows our body to move easily and fluidly, but it's also the reward chemical. If you eat a bar of chocolate, dopamine goes, I like that, do that again. If you snort cocaine, ton of dopamine goes, do that again. But people that aren't going to be seeking out those risks and high reward in the first place, was their brain always at a higher risk of getting Parkinson's, where they had a lower dopamine level to start with. With some of the medications that we use for Parkinson's, we're giving you dopamine, or we're giving you something that works like dopamine, or that increases your brain's dopamine. It'll help your body move. But in some people, especially younger men who do have a history of more risk-taking behavior, they're at a very high risk of dopamine dysregulation syndrome, where they might start taking risks. They might take more of their dopamine to get hit. They might start shopping and spending. They might start gambling. They might start soliciting sexual relationships outside of their partner. And, you know, where is that line between this is what a brain was primed to do versus what the medication? So those impulse control disorders that can come from the medicines. That's a really interesting question in terms of the brain we're born with, the brain and how it changes through our exposures, both positive and negative in our life, and the genetics, right, that might run along with both increase and decreased risks of all these things. Really interesting question. So, about 2 minutes. Gonna finish these slides. So, if the things without medicines aren't working, and we have to do something, the person's not safe, the person's upset, the person's distressed, we got to do something. Antipsychotic medications all work, with one exception, by blocking dopamine. Not a good idea. Somebody has Parkinson's, right? So not only could it worsen the symptoms of Parkinson's,
by completely counteracting your levodopa, whatever else you're on that's increasing your dopamine, and cause more stiffness and slowness and shakiness. And people without Parkinson's who get started on these medicines start looking like they have Parkinson's sometimes, called drug-induced Parkinsonism. But not only will it make the Parkinsonism worse, it can also cause very severe side effects to the point that people can be comatose. So we often put these medicines as allergies in people's charts when they have Parkinson's or Lewy body. Because then if you're in the hospital trying to get your hip replaced and you get confused in the middle of the night because you're in pain and they're waking you up all night, you get confused and agitated, the nurse calls the intern. Never go to the hospital in July or August. If you need to schedule a surgery, don't go in July or August. That's something the doctors are. They call the intern overnight, say, oh, you know, Mr. So-and-so is upset. Can we give him some Haldol? Yeah, sure. Boom, boom, boom. So number one, we try to keep people with Parkinson's out of the hospital unless we absolutely have to. And aware and care kit, that's my last slide. Get your aware and care kit from the Parkinson's Foundation. It's free, it's $8 shipping, and it's a little kit for you to bring with you to the hospital to make sure everybody knows you have Parkinson's, what they can and cannot give you, what you're on right now, keep me safe. Ask me about my Parkinson's. There's a little magnet that goes on that little whiteboard in the room where the nurse writes on it every day. Can't use these medicines. Very unsafe. But you gotta do something, right? So for a very long time, we only had two options for treating hallucinations